You know that specific kind of guilt that hits you around, say, January 17th?
Oh, I know it well.
You started the year ready to conquer the world. You bought the expensive running shoes. You downloaded the language app. You swore this was the year.
The new year, new me energy. It's a powerful, intoxicating drug.
Exactly. And it lasts about, what, 2 weeks? If you're lucky?
If you have iron willpower, maybe 3?
Right. And then life happens.
Yeah.
The boss calls a late meeting, the kids get sick, you miss 1 day, then you miss 3.
And suddenly the running shoes are gathering dust, and the language app is sending you these passive-aggressive notifications.
And you
stop.
It's the universal struggle of human consistency. We're incredible at starting things. We are terrible at sustaining them.
Which, for most of us, just means we wasted $50 on a gym membership. But today, we're not talking about flossing or learning Italian.
No.
We're looking at a scenario where quitting has, well, significantly higher stakes. We're diving into the world of therapy, specifically physical therapy, occupational therapy, and speech-language pathology. Right, this is the arena where quitting isn't just a lapse in discipline, it's a lapse in health. When you drop out of a post-stroke protocol or a post-surgery rehab plan, you aren't just losing a streak.
No.
You might be compromising your long-term ability to walk without pain, or use your hands, or communicate with your family.
And yet, the data shows that people quit these critical therapies constantly, even when it's working, even when they like their therapist.
It's a huge problem.
So today's deep dive is strictly focused on the psychology of staying. We are unpacking a fascinating article titled Enhancing Patient Retention and Satisfaction in Therapy Practices. It was written by Oliver and published just recently on January 9, 2026 by the team at Prime Credential.
And it's a really crucial piece of writing because it bridges that gap between the clinical side, the actual medicine, and the behavioral science side. It's asking the question, how do we actually get human beings to stick with a difficult, painful, expensive process until they actually better?
And our mission today is to hand you the proven strategies from this source. Now, I want to be clear right off the top. If you're a clinic owner listening to this, yes, retention keeps the lights on. It's a business metric.
Of course.
But the source makes a very specific point, that retention is actually a clinical tool.
That is the core argument we have to start with. Satisfied patients are statistically more likely to complete their care plans, and completing the care plan is the only way to get the outcomes.
No.
So in this context, retention literally equals recovery. If you can't keep them in the room, you can't heal them.
So let's set the stage. I want you, the listener, to put yourself in the patient's shoes for a second. You're in pain. Maybe you just had rotator cuff surgery.
It hurts to sleep. It hurts to drive.
You're embarking on this journey of rehab. It's going to be hard work. It's going to cost money. What actually makes you stay? What makes you drive to that clinic week after week when you'd rather be doing literally anything else?
Well, to understand that, we first have to look at the sheer scale of the problem, because the numbers in this report about how many people don't stay are frankly alarming.
I honestly had to double-check this stat because it seemed too high.
Oh.
The source cites research showing that about 73% of physical therapy patients miss at least one visit.
73%. It's a massive number.
That's nearly 3/4 of everyone walking in the door. And I think the knee-jerk reaction from a provider might be, well, people are busy.
They have work. They have kids.
Right, it's just a scheduling conflict.
And look, that's true. Life is busy. But we have to be careful not to dismiss that 73% as just flakiness. There are two massive costs hidden in that number.
Okay.
First, there's a business cost. If you're a clinic, that is revenue just evaporating into thin air. You have the stats, the lights are on, but the table is empty.
Right, that's the bottom line. But what about the patient?
That's the second, more dangerous cost. When you're dealing with a rehabilitation protocol, let's say for a tendon repair, that tissue needs specific load at specific intervals to remodel. Missing visits creates these gaps in care that interrupt the physiological adaptation.
So it's not just that I missed a workout, it's that I've actively disrupted the biology of my own healing.
Precisely. You're essentially resetting the clock on the tissue every time you have a significant gap. So closing this retention gap isn't just about making money, it's about making sure the patient actually gets well.
Okay, so we have this massive problem. We know it's bad for business and bad for the body. How do we close it? The article points to one strategy that seems to be the absolute gold standard. But I have to admit, when I first read the term, my eyes kind of glazed over a little bit.
Let me guess. Shared decision-making.
That's the one. It sounds like corporate buzzword soup. Let's hold hands and decide together. I mean, in a busy clinic where you have maybe 30 minutes with a patient, does this actually mean anything?
It is surprisingly quantifiable. The data in the source shows that 86% of PT patients reported being completely satisfied when their therapist prioritized effective education and shared decision-making.
86%.
Yeah, that is a correlation you almost never see in healthcare data.
That's huge. Okay, so walk us through what this looks like in practice. Because the old model, the one I grew up with, is pretty clear. The doctor's the general, the patient is the soldier.
Do 10 squats because I said so. Ooh,
Exactly.
that's the compliance model. You comply with orders. Shared decision-making is the alliance model. It's the difference between telling a patient, we need to increase your shoulder flexion to 120 degrees, which means absolutely nothing to them.
Yeah, I don't walk around measuring my shoulder angles.
Exactly. Versus asking them, what is the one thing you can't do right now that is making your life miserable?
And the patient says, I can't put the dishes away in the top cupboard?
Boom. Now we have a shared goal. We're doing this stretch not to get to 120 degrees, but so you can put the plates away without dropping them.
That's the why factor the source emphasizes.
It changes the psychology entirely. The source emphasizes that when patients understand the mechanism, the specific link between the torture you're putting them through and the goal they actually care about, commitment skyrockets.
Ah, so they aren't performing a chore for you.
No, they're working toward their own life.
It seems like such a subtle shift, but it respects the patient's intelligence. It stops treating them like a passive body on a table and treats them like a partner in the project.
And that ties directly into the other top driver mentioned, empathy. The article notes that feeling heard is foundational. It's easy for clinicians to get tunnel vision on the injury.
Right.
They see a knee, a back, a hip. How's the knee today? How's the back? But if the patient feels like they are just a shoulder injury walking in the door, they disengage.
Right. They need to feel like a person who has a shoulder injury.
It sounds nuanced, but patients can smell the difference instantly. If you don't know my name or you ask me the same question you asked last week because you didn't write down the answer, I'm already looking for the exit.
You're thinking, this person doesn't care if I get better.
They just care that the slot is filled.
So step one is the emotional and intellectual buy-in. You've convinced me why I'm here. I trust you. I feel like you know me. But then reality hits. The source moves into what I call the friction section. Because I can love my therapist, but if I physically cannot get to the appointment, or if the process is a nightmare, I'm probably going to bail.
We live in the age of Amazon. We are trained to expect zero friction. If buying a toaster takes one click, but booking a therapy session takes 3 phone calls, a voicemail, and a fax.
Oh, fax. Don't get me started on the fax machines in healthcare.
You're going to lose people. The source calls this logistical ease. And the first barrier is simply the clock. Flexible hours are non-negotiable, according to Oliver. The traditional 9-to-5 clinic hour model is basically a retention killer. If you only work when your patients work, you are forcing them to choose between their paycheck and their health.
And in this economy, the paycheck wins.
Every time. Offering evening and weekend appointments isn't just nice to have, it's a structural necessity for retention. You have to meet the patient where they are.
And even if they make the appointment, sometimes they just forget. I mean, the cognitive load of modern life is heavy. I forget why I walked into the kitchen half the time.
That's where automation comes in. The source explicitly recommends automated reminders. But it's not just about sending a postcard 6 months later, it's about text messages. 24 hours before. 2 hours before.
It takes the mental load off the patient.
It does. They don't have to remember. Their phone remembers for them. It's a safety net.
Now, there's another aspect of the environment that the article mentions, which I thought was interesting because it seems so basic. We're talking about the physical space, cleanliness.
It seems trivial, doesn't it? Like, who cares if the waiting room carpet is a little stained?
Exactly. I'm there for the doctor, not the decor.
But think about the subconscious psychology of a medical environment. We call this signal theory. If I walk into a clinic and the waiting room is cluttered, or there's dust on the baseboards or a stain on the chair, my brain immediately starts asking questions.
If they can't take care of the carpet, can they take care of my spinal cord?
Precisely. The source calls these small touches, but they signal professionalism and safety. A lack of cleanliness subconsciously signals a lack of care. And friendly staff works the same way. If the receptionist is rude or even just indifferent, if they don't look up when you walk in, the patient enters the treatment room in a state of defense.
And the therapist then has to spend the first 10 minutes just de-escalating the patient's mood before they can even touch the injury.
Exactly.
Yeah.
It's the whole package. You can't just be a good clinician. You have to run a tight, welcoming ship.
But there is one thing that can sink that ship faster than a rude receptionist or a dirty floor. And I think every listener knows what's coming.
The bill.
Money. Always money.
The source is very direct about this in the FAQ section. Unexpected bills or claim denials are the nuclear bomb of patient trust.
There is nothing worse than thinking you're covered, getting the treatment, feeling good, and then getting a surprise bill 3 weeks later for $400. You feel swindled.
And you never go back, even if the therapy was working. That's why transparency is listed as a vital retention strategy. Being upfront about costs, deductibles, insurance coverage. It isn't just administrative work, it's relationship work.
It sounds like the clinic needs to act almost like a financial counselor.
They do. Here is what this will cost. Here is exactly what your insurance will do. If a patient trusts that you are handling their money and insurance correctly, they can focus on the therapy.
Not on the bill.
Right. If they're lying on the table worrying about whether the session is going to bankrupt them, they aren't healing. We call that financial toxicity. Stress blocks recovery.
Okay, so let's say we've done all that. We have the empathy, the nice waiting room, the text reminders, the clear billing. But we are entering what I call the danger zone. The patient has been coming for a few weeks, and then they start to drift. How does a clinician know a patient is about to ghost them?
The source actually gives us a specific checklist of warning signs. Some are obvious, like showing up late or canceling last minute, but the clinical signs are more subtle.
Like skipping the home exercises.
Exactly. If they aren't doing the homework, they have mentally checked out. But there is one specific phrase the article warns about. It sounds positive, but apparently it's a trap.
I feel fine now.
That's the one.
Now, hold on. I have to play devil's advocate here. If a patient says, "Hey, doc, I feel fine," isn't that a success? Why is that a red flag? Shouldn't we be high-fiving them?
It seems like it should be.
Isn't it unethical to keep treating them if they feel fine?
That is the most common misconception, and it's the most dangerous moment in therapy. Because in rehabilitation, feeling fine usually just means the acute inflammation has gone down.
Okay.
The pain signal has stopped. But the underlying functional issue, the weak muscle, the poor movement pattern, the instability, hasn't been fully resolved.
I see. So the smoke alarm is turned off, but the fire is still smoldering in the wall.
That's a perfect analogy. The patient thinks they have crossed the finish line because the pain is gone, but the therapist knows they are just in the eye of the storm. If they quit now, the pain will likely come back in 3 months because the root cause wasn't fixed.
But this is a tough sell, isn't it?
Yeah.
You're telling a patient who feels no pain to keep paying for therapy and keep doing hard work. How do you convince them?
You have to pivot from pain to function. The source suggests using open-ended questions to expose the gap. You don't ask, does it hurt? You ask, okay, the pain is gone while you're sitting here, but how does it feel when you try to lift that heavy box of books?
You force them to test the real-world function.
Right. You remind them of that original goal. Remember, we aren't here just to stop the hurting. We're here so you can play 18 holes of golf without collapsing on the 9th green.
That brings it back to the shared decision-making. You're referencing the goal they set.
Exactly. And to keep them engaged during this boring strengthening phase, you have to celebrate the micro wins. The source is big on this. Recovery is slow. It's boring.
It's incredibly boring. Leg lifts are not exciting.
So you have to gamify it a bit. Review goals at every visit. Hey, last week you could only lift your arm to here. Today, look, you're 2 inches higher. That visual proof gives them the dopamine hit they need to keep going.
It proves the process is working, even when the pain isn't there to motivate them.
Yes.
Now, we've talked about the human element, but we are living in 2026, so we have to talk about the tech. The source outlines a few tools that act as the invisible back end of retention.
Right. Technology is what keeps the patient engaged during the 167 hours a week they aren't in your clinic. The source highlights telehealth and patient portals.
I think the value of the patient portal is sometimes understated. It feels like the clinic is open 24/7.
It maintains the tether. If I can log in at midnight and see a video of my therapist showing me how to do the exercise, I feel supported. It extends the relationship beyond the 45-minute session.
But there's another side to the back end that the patient usually never sees, but, and here's the connection to the author, prime credential, the clinic definitely feels.
The credentialing beast.
For the listener who isn't a provider, let's demystify this. We hear credentialing and we think boring paperwork, What is it really?
Simply put, it's the vetting process where insurance companies agree that you are a real doctor and they agree to pay you.
Okay. And how does a pile of paperwork affect whether a patient stays or quits?
It acts as a bottleneck. The source explains that credentialing is often the primary barrier to access. Imagine a new patient calls. They're in pain. They have chosen your clinic. They have Blue Cross.
Okay.
You pick up the phone and say, I'd love to help you, but I'm not credentialed with Blue Cross yet. I can see you in 6 weeks when the paperwork clears.
Game over. They hang up and call the next clinic on Google.
Exactly. You didn't lose them because you're a bad therapist. You lost them because of administrative lag. Prime Credential points out that long wait times due to credentialing errors are a huge source of patient attrition before the patient even walks in the door.
So retention actually starts before the first appointment.
100%. If you can't get them in the system quickly, you can't retain them. The source argues that specialized expertise, knowing the specific ins and outs of PT, OT, and SLP credentialing, is essential because these fields have weird nuances that general medical credentialing might miss.
It's about speed and accuracy.
Centralized tracking ensures that deadlines aren't missed, claims aren't denied, and the patient can get in the door immediately. It's the invisible plumbing. If the pipes are clogged, the water doesn't flow.
It really highlights how interconnected everything is. You can be the most empathetic, skilled healer in the world, but if your back-end administration is a mess, the patient never gets to experience your care.
It's a holistic ecosystem. Clinical excellence and administrative excellence have to walk hand in hand. You can't have one without the other.
So let's wrap this up. We've covered a huge amount of ground here. If we had to boil this down to a recipe for retention for a modern therapy practice, what are the main ingredients?
I'd say it comes down to 4 pillars. First, the alliance. Shared decision-making where the patient is a partner, not a subordinate.
Got it.
Second, fictionless logistics. Flexible hours, automated reminders make it easy to say yes. Third, the functional pivot. Don't let them quit just because the pain stops. Guide them to the functional goal using micro-wins.
And finally, the solid back-end.
Yes, transparent billing and efficient credentialing so the administrative side doesn't block the clinical side.
And while the source was very specific to therapy clinics, physical, occupational, speech, I feel like there's a bigger lesson here for anyone leading people or running a business.
Oh, absolutely. The core principle is universal. It doesn't matter if you are running a software company, a gym, or a rehab clinic. People stick with things when they feel heard. Right.
They stick with things when they understand the why.
Yeah.
And they stick with things when you don't put unnecessary barriers in their way.
It's about respect, really. Respecting their time, their intelligence, and their goals.
Couldn't have said it better.
Now, before we sign off, I want to leave you with a thought from the feedback section of the source that really stuck with me. It suggests simply asking patients to rate their experience on a scale of 1 to 10.
The Net Promoter Score approach. Simple, but effective.
But here is the provocation for you. You might think you know how satisfied your people are. You might look around your office or your clinic or your home and see no one complaining. But have you actually asked them? Or are you just assuming that silence means satisfaction? Because as we learned today, in the world of retention, silence often just means they're packing their bags.
And by the time you notice the silence, it's usually too late to fix it.
Something to chew on. That's it for this deep dive into the psychology of staying. Thanks for listening, and we'll catch you on the next one.